Hi, good afternoon, everyone. I think we can go ahead and begin. Welcome to the Department of Psychiatry and Behavioral Health Sciences Grand Rounds. My name is Dr. Marquette Rose, and I'm one of the reproductive psychiatrists here. Today, I'm excited to introduce someone many of you know, Dr. Megan Shedd, who brings to us a unique blend of expertise with today's presentation titled Motherhood, Mental Illness, and Murder, Demystifying Legal Insanity in Cases of Filicide, which examines the intersection of maternal mental illness and forensic psychiatry. Dr. Shedd is currently a Reproductive Psychiatry Fellow here at UNM and also completed her psychiatry residency here. She completed her Forensic Psychiatry Fellowship at Case Western Reserve University. During her training, she received grants to develop community programs and conduct qualitative research. She is a member of the American Psychiatric Association and the American Academy of Psychiatry and the Law, and has served on the latter's committee for gender issues. She has presented at regional and national conferences on the topics of psychiatric malpractice and postpartum psychosis. Her academic interest is the intersection of women's mental health and law. Dr. Shedd, we're so excited to have you here today and presenting on this unique blend of expertise. I'll pass the mic to you.
Oh, thank you. Yeah, I'm very excited to talk about this, but I do want to start with a little bit of a forewarning. So as the title suggests, the content that we're going to discuss today is very sensitive and can be triggering even into the most, veteran mental health professionals. So I just want to let you know it is okay if you need to step away at any point during this presentation, if that's what you really need. So we're going to jump right into it. And first, I want to define some terms that you're going to hear me use throughout this presentation. So child homicide is the killing of a minor child by any other person, while a filicide is the specific type of homicide in which the child is killed by their parent or by a parental figure. A maternal filicide would indicate that the mother is the perpetrator, for example. And then you can further break up filicide into two subcategories, infanticide and neonaticide. And we do this because they're really unique phenomenon, and we want to look at them separately. So infanticide is the homicide of an infant prior to 1 year of age, and it is often associated with peripartum psychosis. And then neonaticide is the homicide of a newborn within the first 24 hours of life. And this is commonly associated with this construct called pregnancy denial or concealment. And so these are the learning objectives, and my goal for the presentation is really to spend the first half examining how to do a forensic sanity evaluation more broadly. And then for the second portion of the talk, I want to give an overview of filicide, and we'll consider how to apply the concept of legal insanity to specific cases of maternal filicide. And in that process, we're going to look at the phenomenon of peripartum psychosis and pregnancy denial. So when there are cases of maternal filicide, it really creates a media storm. These cases are highly sensationalized. There's a lot of public discussion about these cases, and it brings to light a lot of misunderstandings about the connection between mental illness and criminal behavior. So for instance, this is the case of Lindsay Clancy. So she's a nurse and a mother from Boston, and she's currently charged with first-degree murder for allegedly killing her 3 young children prior to an attempt on her own life. Now, her defense attorneys and her husband assert that she was in the throes of a postpartum psychosis when the offenses occurred. Now, the prosecutors in the case, they disagree, and they point to some alleged evidence of premeditation. They claim that Lindsay sent her husband on an errand, tracking exactly how long it would take for him to return home so that she would have time to enact her plan. And Lindsay has entered a plea of not guilty by reason of insanity. And what this demonstrates is that there's a common misconception among the public that a person can't experience psychosis if they have the mental wherewithal to plan a crime. And that's a very important misconception to correct, because jury members are a part of the public and they carry many of these misconceptions. They make major decisions in these types of cases. And it's really the role of a mental health expert to educate the jury about these types of inaccuracies. So mental health professionals are often called as expert witnesses to help judges and juries really contextualize how mental illness can play a role in issues of criminal responsibility and punishment. So the law recognizes that not all people should be held criminally responsible for their crimes. So there are 46 states in the US that give defendants an opportunity to pretty much enact an insanity defense where they assert that serious mental illness played a role in the crime and thus they should be acquitted. And so if a person is found not guilty by reason of insanity, the focus really becomes on treating them rather than punishing them. In the sentencing phase, the law also allows for mental health testimony to be considered around issues of severity of punishment. So for instance, some states will actually bar the death penalty for people experiencing severe mental illness, and every state bars the death penalty if someone has an intellectual disability. So I want to talk a little bit more about what is this insanity defense, what is not guilty by reason of insanity. So it's an affirmative defense. What that means is that the defendant is admitting that they carried out the offense, but they're claiming that there was some justification for carrying it out, or there were extenuating circumstances such that they should not be held responsible. So for instance, self-defense is a common affirmative defense that you're probably aware of. If you assault someone because they attacked you, you'll admit that you assaulted them, but you are claiming you should not be held responsible because there was a justification. That is self-defense. Similarly, if you have such a severe mental illness that it impairs your ability to exercise moral reasoning, or it impairs your ability to control your actions, then you can claim legal insanity. So with an affirmative defense like legal insanity, the question at trial is no longer if the person actually committed the crime. Rather, the question is, was the defendant legally sane or not? And so typically the burden of proof shifts to the defendant. So meaning that the defendant has to present evidence to prove that they met the legal standard, and the prosecution, understandably, is trying to attack that defense. So what is the legal standard? I'm just going to read it to you here. So a person is not responsible for criminal conduct if at the time of such conduct, as a result of a mental disease or defect, he lacks substantial capacity to appreciate the criminality or wrongfulness of his conduct, or he lacks substantial capacity to conform his conduct to the requirements of the law. And so every state has some version of this type of legal standard, but some states actually drop the second prong. And I can break it down further into its constituent parts to help you understand. So first you have to consider, what was the defendant's mental state at the time of the offense? And specifically, you want to look at, was there the presence or absence of a severe mental disease or defect? And these are not clinical terms, these are really legal concepts. So a little bit later, I'll tell you exactly what typically constitutes a severe mental disease or defect. Then you want to consider, did their severe mental disease cause them to not understand that their actions were wrong? We typically call this the cognitive prong of the insanity defense. Or alternatively, you want to consider, did their severe mental disease or defect cause them to not be able to control their actions so that they could not normally exercise lawful behavior? And we call that the volitional prong. And so you can kind of see that this is a very stringent legal standard and it's difficult to meet. And in the states where the volitional prong is dropped, it's an even more difficult standard to meet. Now we're going to get into the specifics of how you conduct a forensic sanity evaluation. So there are some basic principles to a forensic evaluation. that you should be aware of for really any type of evaluation. When you're conducting a forensic evaluation, you don't have the typical doctor-patient relationship. Your role is really to maintain objectivity rather than engage in treatment or provide advocacy. You're answering a specific legal question. There are not the same privileges of confidentiality. So anything the defendant tells you can be put into a report or it can be testified about in open court, but I can't talk to my spouse about the details. So there's some confidentiality, but not the same as a treating relationship. There's also extensive collateral source review. So you're looking at medical records, police records, surveillance footage, witness statements. You might even interview witnesses. You look at medical examiner reports. You look at the reports of other forensic professionals. And in that sense, you're really acting as an investigator. Now, the clinical interview is going to be more open-ended. You really want to minimize introducing symptoms or introducing narratives that the defendant might pick up on. And then every forensic evaluation, you should consider whether the defendant is malingering. So criminal defendants have some interest in escaping culpability. So they might feign or exaggerate symptoms of mental illness. So you want to look for inconsistencies in their narrative and compare that with other sources of evidence. So let's kind of look at each of these constituent parts individually. So an important thing to note when evaluating the mental state at the time of the offense is that the evidence that is contemporaneous, meaning around the time of the crime, is the strongest evidence. So you might look at text messages and computer search history, and you can imagine if the defendant is searching for how to dispose of a body prior to an offense, that'll tell you that there is some criminal motive there. However, if they're searching for something like, I'm hearing God's voice, or I feel like I'm possessed by a demon, that could tell you that they are experiencing psychotic symptoms and also tell you that they have some motive. If you also want to review witness statements, and especially witnesses who were observing the defendant around the time of the crime. So did they notice that the defendant was acting erratically? Were they not aware of any mental illness or any changes to their behavior? Was the defendant making strange statements? Body cam footage from police arriving to the scene, and then interrogation interview footage can be really helpful. You want to look at crime scene photos, and then you want to look at medical records or jail records of evaluations that occurred shortly after the arrest. Those can be really elucidating. Then you want to interview the defendant and collect an account of his or her own narrative about what their mental state was at the time of the offense and in the days and weeks leading up to the offense. You want to understand what are their motives, and ideally you want to interview them as close as possible to the time of the crime because their memory can decay over time. And so then the next step would be making your diagnosis based on their mental state. And you want to consider the course of illness and the onset of illness. So keep in mind that some people develop mental illness after the offense, or even the offense can cause mental illness. For example, developing PTSD due to a violent crime. Also, conditions in jail and the stress of being in a criminal case can precipitate symptoms. So just because they have psychosis in jail 2 years later does not mean that they're experiencing psychosis during the offense. You want to consider the use of medication. So were they having a rare reaction to medication? Were they off medication and thus more likely to be symptomatic? Were they on intoxicating substances? And then you want to seek out corroboration and inconsistencies. And if you find inconsistencies, you want to ask the defendant about them and how they reconcile those inconsistencies. So, like I said, severe mental disease is really a legal concept. And so they're not just considering any diagnosis from the DSM. The diagnoses that are typically considered severe mental diseases for the purposes of legal insanity include acute psychosis due to schizophrenia, delusional disorder, brief psychotic disorder, postpartum psychosis, bipolar mania, even more so if there's psychotic features, and major depressive episodes with psychotic features. And you can kind of see here that psychosis is really the common denominator, because psychosis causes people to really lose touch with reality and develop delusions. There have been some cases of individuals who are experiencing extreme disassociation from PTSD or dissociative disorders who have been successful at mounting an insanity defense. But this is typically really rare because juries are very skeptical of dissociative symptoms. And similarly, severe mental defect is a legal term. It's not the best term, but it's what they use. And so the types of disorders that are usually considered severe mental defects include intellectual disabilities, autism, neurocognitive disorders, TBI, delirium, epilepsy, and brain lesions. So there's also a whole host of disorders that are not considered severe mental diseases or defects. So for one, typically symptoms that arise from acute voluntary intoxication are not considered a severe mental disease or defect. So if you take methamphetamine and you develop psychotic symptoms and then you commit a crime, you really cannot mount a successful insanity defense. Other things that wouldn't be considered severe mental diseases and defects include personality disorders like antisocial personality disorder, borderline personality disorder, paraphilias like pedophilia, impulse control disorders like kleptomania or pyromania, and then milder or moderate forms of mental illness like generalized anxiety disorder would not be considered severe. So once you've established that a defendant has a severe mental disease or defect, now you need to understand and analyze, did this severe mental disease cause the person to not know what they were doing was wrong? And the first step of that is really understanding their motive. So one of the most common symptoms that impairs a person's ability to appreciate wrongfulness is having a delusion that causes them to believe that their actions are justified. So for instance, if you believe your neighbor is flying drones over your house and he's sending electromagnetic radiation through the walls to kill you, you walk next door and you tell him to stop. Of course, he has no idea what you're talking about. Then you shoot him. You might believe in that instance that you're defending yourself. And so you believe you're doing the right thing. Similarly, you might have a delusion that causes you to believe that you're protecting others, or that you're doing something altruistically, like saving the world by making a sacrifice or preventing an apocalypse. And so it's really important to analyze the defendant's moral beliefs about the offense. So having a no comprehensible motive would indicate a deficit in appreciation of wrongfulness as well. So a person with schizophrenia who's very disorganized, let's say they push a stranger off a bridge, and then when you evaluate them, they're completely incoherent, they're not thinking clearly. In that instance, it's clear they really don't have any appreciation of any of their actions, and so they wouldn't be able to understand the morality of their actions. Then you want to consider alternative unjustified motives. So these types of motives would indicate that there is knowledge of wrongfulness. For instance, if you batter someone out of anger, if you kill someone to get a life insurance policy, if you seek revenge on a spouse for cheating on you, even people with serious mental illness will commit crimes for these types of unjustified motives, and that would indicate that they have knowledge of wrongfulness. Further, when you're assessing knowledge of wrongfulness at the time of the offense, you want to search for evidence of consciousness of guilt. What that means is you want to think about what are the things that people do when they know they're behaving badly. So they might dispose of evidence, like hiding a weapon or cleaning up the scene of a crime. They try to evade detection by wearing disguises or committing the offense under the cover of darkness or fleeing a scene. They're secretive, they use deception, they give a false alibi. They might confess guilt to others. They might expect to be arrested, like if the police show up to interrogate them, they run away. because they kind of know that they're in trouble. In contrast, people who think they're doing the right thing, they tend to do the opposite of all of this, right? They tend to tell others, they might call for help, they might call the police and say, I need help. And they might be, honest and open about what they're doing. The second prong of the insanity defense is that volitional prong, which refers to someone's ability to conform their conduct to the requirements of the law. So when you're analyzing whether someone has the ability to conform their conduct, you really want to think about two primary symptoms that can impair volition. One is command hallucinations and the other is bipolar mania. So let's say you have a woman, she's hearing voices of a demon that command her to kill her husband or she will be killed. In her mind, she knows it's wrong to kill her husband, but she really believes she has no other choice. And so that would be an instance where she can't control her behaviors. Similarly, if you have someone with bipolar mania, they're speeding down the highway, they're going 120 miles an hour. They know what they're doing is wrong. They don't meet that cognitive prong of the insanity defense, but they're so disinhibited that they can't conform their behavior to the requirements of the law because of the mania. You also want to consider, can they delay their actions or not? What are the consequences of failing to act? So for instance, I'm going to die if I don't take action now. You want to consider any attempts at alternative non-criminal courses of action. Have they exhausted every reasonable action and now they have no other choice but to commit, to engage in criminal behavior? Okay, so now we're going to turn to the phenomenology of filicide and how to apply these concepts to legal insanity. And once again, I just want to warn everyone that this part of the presentation is really sensitive, and so we're going to be talking about really difficult concepts. And so since motives are such an important part of legal insanity, I think it's helpful to kind of organize our thinking about filicide based on the different motives of filicide. These motives were developed from qualitative analysis of case series of filicides. So it's just important to state they are typologies. So not every filicide will necessarily fall into one of these categories. And sometimes a filicide may fall into both, but they are pretty good at organizing filicides. So the first one is fatal maltreatment. So this refers to child homicides that are the result of fatal maltreatment, like abuse or neglect. The accidental part is in quotes because typically the defendant does not intend to kill the child. And oftentimes the defendant will claim that the death was an accident. So this is the most common type of filicide. And that's not surprising because we know that when you look at all child homicides, parents are going to be the most common perpetrator for children under 10 years of age, and abuse and neglect is the most common precipitant of child homicide. And the most common method used is battery, strangulation, and drowning. Child maltreatment is a major burden in the US. So every year there's about 4.3 million referrals to CPS, with about 550,000 cases that have substantiated abuse or neglect, and about 2,000 child fatalities. We know that youngest children are going to be the most vulnerable to maltreatment, with children younger than 1 having the highest rates of victimization. So what are some of the parental risk factors for child maltreatment? We know they include stress, and so you can think about the motives of anger and frustration. Mental health issues like borderline personality disorder, PTSD, maternal depression. Parents that have a personal history of being maltreated during their childhood, having a substance use disorder, being a single parent, if there's domestic violence in the home, it's associated with low educational status, young age, criminal history, applying excessive discipline, so think like corporal punishment, and then perceived difficulties with the child. And that's really related to poor frustration tolerance around crying and toilet training, which is part of the reason why younger kids are more likely to be victimized. So in these situations, this type of filicide, fatal maltreatment, it's unlikely that the perpetrator will meet criteria for legal insanity. Typically, there is an absence of a severe mental disease or defect. Psychosis is not a major precipitant of abuse or neglect. Not saying that it can't be there, it's just not a major factor. And typically the motives are, almost always the motives are not justifiable. So the next motive is unwanted child. So unwanted child motive often occurs in cases of neonaticide. So this is a young woman, her name is Paris Mayo, and she's currently serving a 12-year term in the UK for murdering her newborn baby. So she's currently 20 years old, but at the time of the crime, she was 15 years old, and she gave birth completely unassisted at her parents' home while they were sleeping. And Paris maintains that she did not know she was pregnant until moments before delivery, and that the baby died as a result of an accident during labor. The baby's remains were found in the trash can later. And so the prosecution in her case argued that she knew she was pregnant, she actually concealed her pregnancy, and she planned the offense. And the jury found her guilty. And so what do we know about neonaticide perpetrators? They're often young, single women acting alone. They're of lower socioeconomic status. They live with their parents. There's no prenatal care in these cases. There's unassisted deliveries that are alone. And the neonaticide is often preceded by pregnancy denial or pregnancy concealment. So I want to talk a little bit about this concept of pregnancy denial and concealment. So pregnancy denial is when a woman is either completely unaware that she's pregnant, or she is in psychological denial of her pregnancy. And this can really exist on a spectrum. And you can move from different, it's kind of on a continuum. So pervasive denial is when the woman is completely unaware that she's pregnant. It just really hasn't entered her perception. So of course, there's going to be physical changes happening to your body when you're pregnant, but she's really misinterpreting these changes. So she might attribute her growing abdomen to gaining weight. She might even take medicine to lose weight. Her missed periods are really just, a regular period. And sometimes you have some spotting during pregnancy, so she thinks that's a period. Any movements of the fetus are interpreted as GI distress. They'll often take birth control. They'll even go to medical providers with complaints of abdominal pain. And when the pregnancy isn't diagnosed by that medical provider, it sort of further reinforces the psychological denial, the unawareness of the pregnancy. And you can kind of see how this could lead someone to neglect prenatal care, go into labor unassisted, and that has, that's really stressful. There's a lot of blood loss, there's pain, and it can be a very frightening, confusing experience for the young woman. And then when they see this baby, they haven't formed any emotional bond to the baby whatsoever. Now, affective denial is when the woman is consciously aware that she's pregnant, but she's not making mental or emotional preparations for the birth. So she doesn't want to accept that she's pregnant. She's in denial. She's in psychological denial and ignoring her reality. This is like a defense mechanism. And then psychotic denial is a rare form of denial where the person has a delusion that they're not pregnant despite evidence to the contrary. Finally, pregnancy concealment is when the person knows they're pregnant, but they're concealing the pregnancy for others, and it may be preceded by a period of denial. So pervasive and effective denial, again, that's being unaware that you're pregnant or being in denial that you're pregnant. These can be mitigating factors, but they're unlikely to be successful at mounting an insanity defense. And this is primarily because the motive around it of an unwanted child is not really justifiable. Also, they typically don't have severe mental diseases in these cases. On the other hand, psychotic denial at pregnancy might actually have a case for legal insanity. So you can imagine if a woman has psychotic denial during the pregnancy, but then she delivers the baby unassisted, she might develop a delusion that this, this is not a baby, but this is a parasite or an alien. And so she believes it's justifiable to kill. And so when you're consulting on these cases, it's really important to determine, was psychosis present? Was psychotic pregnancy denial operative in these types of things? There's many opportunities for prevention of neonaticide, kind of thinking about it from a public health perspective. So access to birth control to prevent unintended pregnancy. We know that half of all pregnancies are unintended. Also, liberal access to abortion services, comprehensive sexual education, raising awareness among primary care providers about pregnancy denial so that they're assessing complaints like abdominal pain in young women women of reproductive age potential. They're doing pregnancy tests. Also, access to anonymous births, which is practiced in Europe, but not very common in the United States, and then safe haven laws. And so we do have safe haven laws that are present in all 50 states, and this is actually the New Mexico statute, and it allows parents to anonymously relinquish an infant who's less than 3 months old to any hospital, law enforcement agency, or fire station, and that parent will not face prosecution for abandonment. So the next motive is partner revenge. And so the concept of partner revenge really dates back to antiquity. In Greek mythology, Medea, who's pictured, killed her children to enact revenge on her spouse. So you want to think about this motive if the mother is going through a divorce or if her spouse was having an affair on her. And typically, this type of filicide is not going to be successful at an insanity defense. And so next is altruistic filicide. This is a filicide out of love. Psychotic symptoms may or may not be present. Some examples might include an extended suicide. So think about a woman who has severe depression. She's suicidal, and she's planning on killing herself. And then she also kills baby because she knows that the baby would be worse off without her in this world and that they'd be better together, united in heaven. You might also have a mother who kills to end the suffering of the baby, and this can be reality-based or based on a delusion. So if, for example, you might have a delusion that a baby has a terminal illness and is being tortured, and you want to end its suffering. And then also deific decree is an example of an altruistic filicide. So in this case, the mother is acting on a command hallucination from God, and she believes that God is, the source of all good. So a famous example of an altruistic filicide is the case of Andrea Yates. She was a married mother of 5 children living in Houston. She was the valedictorian of her high school, a well-regarded nurse, and by all accounts, she was a very attentive mother prior to this offense. Unfortunately, she developed postpartum psychosis after her 4th pregnancy and was told by her doctors not to have any more children. She did not heed their advice. She actually discontinued her antipsychotic Haldol, and she had another pregnancy. So in June of 2001, she was 6 months postpartum. She waited until her husband left for work and then drowned all 5 of her children in a bathtub. She then placed the children in bed, covered them up with a blanket, called the police, and called her husband. She was arrested and taken to jail. And she pled not guilty by reason of insanity. She had 3 psychiatrists testify in her defense. One of those psychiatrists, Dr. Resnick, is pictured. He opined that she had schizophrenia and she was experiencing acute psychotic depression. He said she was experiencing delusions, that Satan was within her, that she had corrupted her children, and that her children were going to spend eternity in hell. She drowned her children because they would go to heaven, saving their souls, and she knew she would be executed, effectively killing Satan. And he opined that due to her severe mental disease, she did not know her actions were morally wrong. Dr. Park Dietz was the forensic psychiatrist for the prosecution, and he conceded that Andrea had a severe mental disease. He agreed that she was psychotic at the time of the offense. However, his opinion was that she knew her actions were illegal and wrong. And he based that on evidence that she hid her children out of shame, she called police, and she knew she would be arrested. Also, that she took directive from Satan. So thankfully, she was found not guilty by reason of insanity, and committed to a psychiatric facility where I believe she still resides. And this case demonstrates a very interesting distinction between this concept of moral versus legal wrongfulness. So you might know your actions are illegal, thus understand legal wrongfulness, but there's some overarching moral principle driving your actions, so you really can't appreciate the moral wrongfulness of your actions. Another important point about this case is that Andrea admitted to planning out the crime, and that's why she waited for her husband to leave. She knew that if she started to enact her plan, he would stop her. So this can demonstrate how a person can experience psychosis, commit a premeditated crime, and still be found legally insane. And so these types of altruistic filicides in the setting of psychosis are going to have the highest success rates for an insanity defense. And there are a few things to keep in mind when you're evaluating cases of maternal filicide and you suspect that postpartum psychosis is operative. So postpartum psychosis can have a very unique presentation. It can have an abrupt onset. It's typically between 2 to 4 weeks following delivery, but can really happen at any time in the postpartum period. There may be a delirium-like presentation that waxes and wanes over time. And this is important because to witnesses, they might see her one moment looking really good, but other times, she's very confused. And that can be perceived as inconsistencies in her report. We know that it's associated with bipolar disorder, but really half of all women who have postpartum psychosis have no psychiatric history. And that's important because juries are often really skeptical. They're already skeptical about insanity defenses, but they're really skeptical if you don't have a past psychiatric history of serious mental illness. And then for our own clinical practice, we know that there is an estimated 4.4% risk of infanticide, and this is one of the reasons that postpartum psychosis is an emergency. So I want to tell you a little bit about this case control study. This compares women with postpartum mental illness who've committed infanticide to a control group of women with just postpartum mental illness. And what it shows is there are higher odds of psychotic symptoms and insomnia in the infanticide group compared to the controls. Another thing that's very interesting about this study is that the postpartum control group had slightly higher odds of having thoughts of harming the baby, which doesn't surprise me working in reproductive psychiatry, because we know that infant harm ideation is really common in the postpartum, and it's often associated with OCD, which doesn't carry a risk of enacting the harm on the infant. So this study really underscores the amount of risk that psychosis and combined with insomnia can really pose in the postpartum period. And then finally, we have acutely psychotic, which I think is better termed no comprehensible motive. So you might have someone in this that fits this motive if they have disorganized psychosis, they have delirium, they have a seizure or post-ictal confusion, or they have a moderate to severe neurodevelopmental disorder. And you can tell by the nature of all of these disorders that a person really wouldn't be able to appreciate their actions, nonetheless, the wrongfulness of their actions or control their actions. And so some key takeaways, mental health experts play an important role in correcting misconceptions about mental illness and criminality. Legal insanity is an affirmative defense available to criminal defendants with mental illness. but it's a very stringent standard. It's important to analyze motives when conducting evaluations of legal insanity. Since you're evaluating the defendant's mental state at the time of the offense, you really want to look at contemporaneous collateral sources. These are going to be very important. And then fatal maltreatment is the most common type of filicide, but it's not likely to meet legal insanity criteria. And non-psychotic pregnancy denial might be a mitigating factor for neonaticide, but it's unlikely to be successful at an insanity defense because of this unwanted child motive, as well as typically lacking the severe mental disease aspect of insanity. Infanticide due to postpartum psychosis is likely to have a credible insanity defense if the motive is altruistic or if there is no comprehensible motive. So I think because we have a little bit of time, I actually want to do this case. And what I'm going to read it out loud. And what I want to ask you to do is either unmute and tell me if you think this person has a severe mental disease and if they meet criteria for legal insanity and why, or you can just put it in the chat. So Miss Doe is a 32-year-old mother of two with no psychiatric history. She is charged with first-degree murder for killing her two young children. She is pleading not guilty by reason of insanity. She was 8 months postpartum at the time of the offense. 3 weeks prior to the offense, her husband filed for divorce. After she discovered he was having an affair, he moved out and she maintained custody of the children. In the spring of 2015, she killed her two children and then placed them in the bed. And she wrote a note to her husband stating, "You wanted your life, now you get it, but I'd be damned if you get the kids too." She then attempted to kill herself by puncturing her lung, cutting her wrists, and cutting her eyelids. She was admitted to a psychiatric hospital. She was examined there by doctors, by psychiatrists, and they were convinced that she was experiencing depression, delusions, and hallucinations. Now, when you finally get the chance to evaluate her as an expert witness, she tells you that she was hearing Satan commanding her to kill herself and that she wanted the children and her to stay together. So go ahead and put in the chat what you think. Let me see if I can see it. And if anybody wants to be brave and tell me what they think, that would be great. Okay, Javier Ortiz says not guilty by reason of insanity. And Nathan says guilty. Does not meet criteria, not legally insane. Okay. So some good responses. Let me tell you what I think. Does she know what she did was wrong? That's really up for you to determine. I want to know more about the inconsistencies. Disagree with the psych hospital, not insane. Okay, I'll tell you what I think. I just am going to assume that, all of these are facts. Of course, we'd want to confirm inconsistencies, but let's assume she really has psychosis. She really has delusions. I would say she does have a severe mental disease. She was hearing voices of Satan that were commanding her to kill the children. I wouldn't think that I would think that she understands wrongfulness because she's taking, she has sort of the motive of seeking revenge on her partner, but I do think there's a potential chance that she was not able to conform her conduct because command hallucinations from Satan are very powerful. So imagine if you put yourself in her shoes and she's hearing the voice of Satan, this would be really alarming, and it might prompt you to carry out something like murder. So I do think in some states that have that second prong, she could be found legally insane. In other states that only have the knowledge of wrongfulness prong, I think that she would not be considered legally insane. So now I want to open it up to questions. Let me go ahead and stop the share.
So, may I?
Of course.
Thank you very much, Megan. This was a wonderful presentation. I really enjoyed it and found it very helpful. So going back to Andrea Yates' case, you know, I heard about it many years ago, but I'm really not fully familiar. But you mentioned that she had been taking haloperidol and she stopped the haloperidol and
Correct.
she got pregnant.
Correct.
Yeah, so she made that choice.
Right.
And could you comment on how does that compare, the similarities and the differences between that choice and someone who has no mental illness and chooses to use meth and get psychotic and hurt someone, and how in her case, you know, she was exonerated based on a reason for insanity.
Right.
But you made it very clear that that's not a defense for someone who becomes intoxicated and becomes psychotic and then hurts someone.
Correct. Yeah. So that brings up interesting question. So for one, I think that the law distinguishes between decisions that we make of sound mind. So for instance, if you're taking methamphetamine, at the time that you take it, you have all your faculties, you're making a knowing decision, and you should be aware of the risks of taking substances. And so it might go in, you know, you might have some mitigating factors that if you weren't aware that meth makes you psychotic, but they'll kind of look at your history. If you in the past have been psychotic from methamphetamine, and you're aware of the risk, then you're really responsible for changing your behaviors. This would be different if you have schizophrenia or bipolar disorder. And we know that part of the illness of schizophrenia and bipolar disorder is really having absent insight into taking medications. And so I think that'll be really important, explaining to a jury that this absent insight comes into play. Now, let's say you do have insight, you know, you just decide to come off the medication, you assume the risk. I think you're making a good point, but the law really just doesn't really consider that. They typically absolve people with serious mental illness of crimes if they become psychotic, even if they're non-adherent with medications. And I think that the rationale is that like this disorder is just completely involuntary and out of your control, whereas things like intoxication from substances are just really stigmatized in the legal system. And that's, you know, they think that's fully within your control. I hope that answers the question. Did you have another one? I think that was it though. Okay.
Lovely presentation, Dr. Shed. Could you please give your advice for folks who may come across an ambiguous situation and how to help everyone think about that risk assessment, especially with the waxing waning presentation of postpartum psychosis and that idea that thoughts of harming a child are pretty common in postpartum, but other things may be more helpful to consider?
Yeah, this is a great question. We actually have a patient right now who is in her third trimester, who's having chronic psychosis, and I'm really worried about what's going to happen when she delivers. My suggestion if there's any psychotic symptoms in the postpartum and the person does not have good insight, so if they're delusional and they just can't reality test, their insight is impaired, I would say that's an emergency and that they should you should do a risk assessment, and I would say they're high risk, and you should mitigate that risk by either hospitalizing them or having some support around them where they're receiving 24/7 supervision. And I wouldn't clear them to be safe to take care of the baby or be alone with the baby. until they're in complete remission. And that's just because we know that psychosis is such a high risk factor for infant harm because, and I usually tell people, like I warn them about postpartum psychosis. It's rare, thankfully, but it is a complication of childbirth. And this is what to look out for. And we know that, unfortunately, when moms develop psychosis, they might think that they're helping the baby, but inadvertently cause harm. And I think that's a really good way to frame it with patients. So that's what I'm thinking. Now, if you have OCD, if you just have a mom with OCD, which can sometimes be hard to tell between the two, OCD does not carry the same risk of infant harm that psychosis does. Those thoughts of infant harm would be really distressing and they would be intrusive and it would just be so confusing, and they'd tell you they don't want to harm the baby and there wouldn't be delusions associated with it. And so that is not an emergency, and you wouldn't want to separate mom from baby. In fact, you'd actually want to do therapy, some behavioral therapy and exposure therapy to help have them cope with being around the baby, rather than separate mom from baby, which can be really harmful. So I hope that answers your question.
Yes, thank you.
Dr. Shedd, great presentation. I'm questioning, like, is there anything we should be mindful on an inpatient standpoint or even PES in our documentation? You know, I've had patients in PES come and maybe there's a fear of like, please don't document, I'm having this thought, you know, is anything that we document, could that be incriminating, and what should we be considering there?
Yeah, that's a wonderful question. I'm so glad that I wanted to talk about this. I do think, you know, if there is a lot of times after a serious incident, like filicide, if there is psychosis, they'll be hospitalized, and then you kind of worry, I don't want to harm this person by documenting things that are incriminating. And I would just encourage you to not worry about that too much. I will let kind of the criminal justice system, it's flawed, but let it do its own thing on that side, and you just focus on treating the patient. And actually you may find that what you document actually helps in their case of insanity. And so so that's one kind of point, is to just document like you would document any other patient. I do think there's specific things that you can document if you know, a patient's coming at you with thoughts of infant harm. You should kind of document a risk assessment. You've identified protective factors and risk factors. You can explain how I think this is OCD and that's not associated with increased risk of harming baby. If you're seeing both, we've had some cases where you see both psychosis and OCD. I think if there's any psychosis or any question of it, probably get them 24/7 supervision or hospitalized until proven otherwise, until you can further evaluate them on an inpatient unit and really suss out what's going on. And it might be just a short hospitalization just to make sure that everything is safe. And I would just encourage, you know, more documentation in these situations than not, just to also protect you from a liability standpoint. Okay, Dr. Quinn, do you have a question?
Yes, hi. Thank you, Dr. Shedd. Wonderful presentation. It's really great to have you back here at UNM and taking advantage of your expertise in now multiple areas. So one of the points that I think maybe you mentioned briefly a few minutes ago was about, you know, is it safe to send a baby home with a mother who's got a serious mental illness and is psychotic? And I remember a case like exactly about that from CL, that we were asked to say, is the baby safe to go home with the mother who just gave, and they've been off all antipsychotics and they're disorganized and psychotic. And one of the things that I remember asking myself was, is the content of the psychosis or their ability to safety plan and say, I have no thoughts whatsoever about harming my baby, I want to take care of my baby. I want to do all the things. They're able to sort of like say very reassuring things, but they also have psychosis. Like, does the content of the psychosis or their ability to safety plan around the child have any bearing in sort of whether you permit them to go home with the baby or not?
So that's a great question. I would exercise extreme caution. I think I wouldn't think of it as the fact of the matter is that if they're having psychotic symptoms and there's some impaired insight, they might have partial insight. We see that a lot. There's always and it's foreseeable that they could get worse. So maybe they're not on meds. It's foreseeable they're going to decline. Then I wouldn't clear them. But let's say you have everything in place. You have them on medication. They've improved a lot on this medication. They just haven't reached full remission, but they're having some delusions. They're just not about the baby. I would still want them to be supervised 24/7. That would be I think you could make a safety plan, but I would expect them to, mobilize some support and be supervised at home until they're free of any psychotic symptoms. And that's coming from a place of evaluating people in forensic hospitals for dangerousness and conditional release. So like they've already been found in GRI, we're releasing them into the community. And we know that psychosis is a huge risk factor for violence. So I wouldn't feel comfortable sending them home with any level of psychosis, as long as that's coming from a psychotic disorder. Sometimes people have hallucinations and they're not quite, maybe they're a trauma disorder. But if it's coming from a psychotic disorder, I would send them home with supervision until they're in remission.
Thanks very much. Appreciate it.
It's even more dangerous if the delusions involve the baby, but it's still dangerous if they're having any kind of delusion. Gregory?
Hi, thank you for your presentation. It's been really interesting. I had a quick question on the differences between what the law considers, what disorders the law considers. You can have a plea for insanity in our psychiatric assessments that may impair insight that led to a behavior. And there seems to be disparity between states. And I'm curious, how is that kind of dealt with? Is there like still some kind of standard nationally that's all, even though there's large variance between states? It just seems to really dictate, like, although psychiatrically we are pinpointing that the insight's lacking, the law can kind of override that.
Yeah, that's a great question. So there's a huge variation, and in short, the law doesn't give us great guidance on what sort of things are severe mental diseases or not. So it's typically up to the jury to decide. And that can bring a lot of, that can cause psychiatrists and forensic psychologists to kind of bring their own attitudes about what constitutes severe mental disease into the picture. Some states do explicitly exclude like certain personality disorders, or they specifically exclude in the statute voluntary intoxication. And so it's really helpful for those states because you have a little bit more guidance about what a severe mental disease is. But really, yeah, we don't have a lot of guidance, and it's sort of you're left up to the profession a lot of times to decide. And so that's why you get, all kinds of interesting theories about what kind of symptoms people are having at the time of the offense. So I think we need more guidance. That would be really helpful. But the problem that we can run into is that the law just really isn't up to date on mental health and what constitutes a mental illness. And so sometimes they just have really weird non-evidence-based guidance that we have to abide by.
And I might be wrong, but my understanding is some states have inclusion criteria and not necessarily like exclusion. So you're trapped. Do they have these 3 or 4 disorders?
Right.
And everything else is just kind of like, well, sorry,
Yeah,
and it's just such a variance from state to state on something so important, it seems.
Yeah, exactly. And it poses a problem. For instance, postpartum psychosis is not in the DSM. And so maybe you can't diagnose this woman with bipolar disorder because she doesn't have a history of mania, but you know she has a severe mental disease, but you're in one of these more restrictive states that just, you know, has bipolar disorder, schizophrenia, and major depression with psychotic features as like the 3 diagnoses you have to have. So it does cause problems, and there needs to be kind of more of a standard across states.
So that puts us at time. Dr. Shed, thank you so much for bringing your expertise to our department and taking the time and effort to prepare this presentation for us all today.
Great. Yeah, if anyone wants to chat about forensic issues, I'd love to talk. So just shoot me an email.